Hello, my name is Kate Chesterman. I'm a salaried GP in South Norfolk, and I also co-host the GP Notebook study groups. Welcome to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify, Apple Podcasts, and Google Podcasts. Please follow us to receive notifications about new episodes, and if you like what you hear, please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. Now today I'm going to be discussing restless legs, and we're going to think about the diagnosis of restless leg syndrome, possible associated conditions, differential diagnoses, and treatment options. Let's start, as we often do, with a case study. Jasmine is a 29-year-old lady who is 33 weeks into her first pregnancy. She comes to see you because she's increasingly troubled by odd sensations in her legs in the evenings and at night. She describes a feeling of insects crawling on her legs and a need to keep moving her legs. When she does move, the odd sensations go away, but they return when she stops moving. This is now starting to disturb her sleep, and she's having difficulty getting to sleep because of the need to frequently move. She wants to know what is going on. Is this to do with her pregnancy, and what can be done to make it better? So, as we will see, the symptoms that Jasmine are describing are classic of restless leg syndrome, which is a neurological disorder whose pathophysiology is not fully understood. It is thought that it may occur due to a dysfunction of the dopaminergic system, and that lower levels of dopamine might result in spinal hyperexcitability and the symptoms of restless legs. This theory is supported by the knowledge that dopamine activity has a circadian rhythm, which may explain the diurnal variation in symptoms. And the improvement in symptoms when treated with dopamine agonists is also supporting evidence for this theory. Conditions that result in lower iron stores, such as pregnancy and renal failure, predispose to restless leg syndrome. And this may be because the rate-limiting step of dopamine synthesis requires iron. So around 20% of pregnant women are affected, often in the third trimester, and around 30% of patients with end-stage renal disease undergoing dialysis also suffer with RLS. And this can be particularly difficult to manage, as the prolonged rest needed for dialysis tends to exacerbate the restless symptoms, and this can lead to an early cessation of dialysis for many patients. There are several psychological and behavioural conditions, such as depression, anxiety, and ADHD, that appear to be associated with restless legs, but there is no good evidence of causality. In addition, there's limited evidence of an association between RLS and other neurological conditions, such as Parkinson's disease, MS, spinal stenosis, and peripheral neuropathy, as well as conditions such as diabetes, obesity, obstructive sleep apnea, and fibromyalgia. Iatrogenic RLS can occur due to drugs such as antidepressants, some antipsychotics, sedating antihistamines, dopamine receptor blockers such as metoclopramide and prochlorperazine, some antiepileptic drugs, and beta blockers, as well as excess caffeine, alcohol, and chocolate. Restless leg syndrome can also be familial, and it's thought that around 50% of people with RLS have a family history, and it's most commonly inherited in an autosomal dominant pattern, but the inheritance can be more complex, and no specific gene mutations have been identified. So, how do we diagnose RLS? Well, the International RLS Study Group state for a diagnosis of restless leg syndrome to be made, all the following criteria must be met. Firstly, the patient should experience an irresistible urge to move the legs, usually, but not always, accompanied by or felt to be caused by uncomfortable and unpleasant dysesthesia. Dysesthesia describes unusual sensations that can become intense or painful. And in restless leg syndrome, they are often described by patients as creeping, crawling, tingling, burning, cramping, fizzing, or aching sensations. The lower extremities are affected more frequently, but in severe conditions, the upper limbs and trunk can also be affected. Secondly, the urge to move the legs and any associated sensations begin or worsen during periods of rest or inactivity. They are relieved at least to a degree by movement for as long as the activity continues, but they will return when the patient tries to rest. And finally, for the diagnosis of RLS, these symptoms should not be attributable to another condition, for example, leg edema or cramps, positional discomfort, or habitual foot tapping. Sometimes the symptoms can be very mild, and so for the condition to be deemed significant, the symptoms should cause significant distress or impairment in functioning by their impact on sleep, energy, daily activities, behaviour, cognition, or mood. It's well documented that RLS can result in sleep disturbance, anxiety and depression, loss of work productivity, and an impact on quality of life that is comparable to conditions such as type 2 diabetes and osteoarthritis. NICE recommend that we use a validated symptom rating scale, like the one produced by the International RLS Study Group, to grade the severity of symptoms and the impact on a person's life. And I've included a link to this in the show notes for this podcast. This can also help to assess response to treatments and monitor progression of the condition. So as we can see from these diagnostic criteria, the diagnosis is really based on the history. And a good history can help rule out potential differential diagnoses, such as periodic limb movement disorder, where patients get repetitive limb movements that only occur during sleep, without the patient's awareness and without the need to move to relieve the symptoms, as well as positional discomfort, nocturnal leg cramps, and akathisia, where patients have a feeling of inner restlessness that is a central discomfort rather than uncomfortable symptoms in the legs. And the history can also be useful in determining any triggers or exacerbating factors, such as smoking, excess caffeine or alcohol, stress, obstructive sleep apnea, and lack of exercise. Assessing the frequency of symptoms is also important and should be covered in the history, as this can affect treatment choices. Chronic persistent RLS is defined as an average of at least 2 episodes weekly for the past year, whereas intermittent RLS is defined as an average of less than 2 episodes weekly in the past year, but at least 5 lifetime events. A physical examination is usually normal in RLS, but again can be helpful to rule out other differentials, such as a DVT, peripheral neuropathy, or arthritis, as well as to elicit any underlying causes or triggers. There are no investigations to confirm the diagnosis, but it is recommended that at least a ferritin is measured in all people with RLS due to the association with iron deficiency, and actually full iron studies comprising serum iron, ferritin, total iron binding capacity, and transferrin measured on an early morning fasting sample would be preferable. Other investigations can be added depending on the patient's history and examination. And so, for example, you could consider adding a full blood count, Usinase, LFTs, thyroid function, HbA1c, and B12 and folate if this was felt to be appropriate. So let's start thinking about options for the treatment of RLS. And we're going to start by considering the first 2 principles of management, and they are addressing any underlying causes and self-help. We'll start by thinking about how to address underlying causes. Now, as we've established, iron deficiency is strongly associated with restless legs. And if iron deficiency is noted, then the cause of this should be investigated by following the well-documented iron deficiency pathways, and the iron should be replaced with supplements if appropriate. The BMJ best practice paper advises treating if the ferritin is less than 75 and the transferrin saturation is less than 45%. Patients should be reviewed every 3 to 6 months, and we should aim for a ferritin over 100. If the ferritin is not increasing with oral supplements, then consideration needs to be given as to why, as well as a possible referral for iron infusions. We should undertake a drug history and consider changing or stopping any precipitating medications if possible. In addition, we should refer if there are concerns about obstructive sleep apnea, as effective treatment of this condition may improve the symptoms of RLS. In pregnancy, we should offer reassurance. The symptoms of restless legs usually resolve in the month after delivery, and drug treatment is not recommended in pregnancy or breastfeeding without specialist input. In terms of self-help, it's important to encourage good sleep hygiene, and patient information leaflets can help support this. I've included a link to some useful patient advice in the show notes. Recommending that patients reduce caffeine and alcohol and stop smoking can also be of benefit to those in whom this advice is applicable. Regular moderate exercise has also been shown to be of benefit. During an acute attack, patients can find it helpful to walk and stretch, apply heat, and massage the affected areas. Relaxation exercise and mental alerting distraction activities such as games or crosswords can be useful at times of boredom. So, with our case study Jasmine, we reassured her that her symptoms should resolve soon after delivery. She tried a combination of heat and massage during attacks, worked hard to improve her sleep pattern, and increased her regular exercise. Her symptoms improved a little, and she was able to manage them for the duration of her pregnancy. And when she came to see you for her 6-week check, she was very pleased to report that her restless leg symptoms had completely resolved. Fast forward several years, and Jasmine, now aged 36 and not pregnant, comes to see you concerned that the restless leg symptoms appear to be returning. And unfortunately, this is not an uncommon situation, as transient RLS in pregnancy is associated with a 4-fold increased risk of developing restless legs in later life. Jasmine had tried the self-help methods that had been advised during her pregnancy, but was still experiencing increasing symptoms. She was affected by episodes 3 to 4 times a week, and was now suffering from a degree of sleep impairment that was affecting her ability to work. There were no obvious triggers in her history, and you undertook some baseline bloods that did not show any iron deficiency. Jasmine scored in the moderate severity range on the symptoms rating scale and was keen to explore drug treatments. So considering drug treatments is the third principle of the management of RLS, and is appropriate for those with moderate or severe symptoms who have not improved with the management of underlying conditions or self-help. The 2 first-line treatment options that can be considered are either the gabapentinoids, used off-label for the management of RLS, or non-ergodopamine agonists, such as pramipexole and ropinirole. The dopamine agonists used to be the preferred treatment option, but unfortunately are associated with a high number of complications, which we'll discuss in a minute, and this has led to a shift towards prescribing gabapentin or pregabalin first. The gabapentinoids can be particularly helpful if there is significant sleep disturbance or comorbid anxiety or pain, or if there is a history of side effects with the dopamine agonists. For restless legs, pregabalin is usually started at a dose of 75 milligrams for those under the age of 65 and 50 milligrams for those over 65. It can be titrated as guided by the BNF for other conditions, and the maximum dose in RLS is 450 milligrams per day. Alternatively, gabapentin can be initiated at 300 milligrams for those under 65 and 100 milligrams for those over 65. Again, it can be titrated as per the BNF, and the maximum dose of gabapentin for RLS is 2,700 milligrams per day. The potential side effects of the gabapentinoids are listed in the BNF, as are the cautions and contraindications, and it's worth reviewing these prior to prescribing. Dopamine agonists are sometimes preferred in those with severe symptoms, obesity, depression, a higher risk of falls, or cognitive impairment. The doses and titration of the dopamine agonists for use in RLS are listed in the BNF, along with the cautions and contraindications, but I do think it's worth being aware of some of the significant complications associated with these agents. So dopamine agonists can result in increased sleepiness and episodes of sudden sleep onset. This can occur rarely without awareness or warning. Caution therefore needs to be exercised if patients are driving or operating machinery, and they should avoid concomitant use of other sedating drugs or alcohol. One of the major complications of dopaminergic treatment for RLS is augmentation. Augmentation of symptoms due to dopamine agonists is characterized by worsening symptoms that may occur earlier in the day, at increased intensity, or may spread to the upper limbs or trunk. The symptoms are often worse than before treatment was initiated, and augmentation should be considered if there is a maintained increase in severity despite appropriate treatment escalation, especially if the symptoms actually improve on reducing the dose. It is a long-term consequence that can occur months or even years after treatment has started. If concerns about augmentation develop, then it's worth checking a ferritin and asking about any lifestyle changes that may have led to a worsening of symptoms and therefore mimic augmentation. If the symptoms are severe, then the offending drug will need discontinuing. For milder symptoms, dividing the dose or taking it earlier in the day before the symptoms start can be helpful in some cases, but if dose adjustments fail, then the drug will need to be stopped. Impulse control disorders are another significant potential complication of dopaminergic agents and should be discussed with patients and their carers before initiation and at every review, as patients must be aware of the risks. Impulse control disorders can present as pathological gambling, alcohol or drug addiction, binge eating, hypersexuality, or excessive shopping. And dopamine agonists should therefore be avoided in patients with a history of impulse control issues, such as drug or alcohol abuse. If symptoms develop, then the dose needs reducing until the symptoms resolve, and the drug may need to be completely withdrawn and replaced with a non-dopaminergic agent. Loss of efficacy can be an issue with all drug therapy in the long-term treatment of RLS, and patients may find that increasing doses are needed to maintain the same control of their symptoms. Unlike augmentation, symptoms are not worse than before treatment was started. But again, it is worth checking for iron deficiency and other causes of worsening symptoms. But if there are no reversible causes and you're reaching the maximum dose of the prescribed medication, then it would be worth seeking advice as to the benefits of adding a second agent versus switching to a drug of another class, as opinions seem to vary as to which confers the greatest benefit and smallest risk. Treatment for idiopathic, chronic, persistent RLS is likely to be lifelong, but it is felt to be reasonable to suggest a drug holiday, maybe on an annual basis, to see if there has been any improvement in symptoms and if the treatment is still required. It's good practice to prescribe the lowest dose of any medication that controls the symptoms to reduce the risk of side effects and complications. And it's also worth setting realistic expectations of treatment at the outset. Any drug therapy will hopefully reduce symptoms, but a complete resolution is unlikely. Weak opioids, such as codeine, or hypnotics like benzodiazepines or Z drugs can be considered for short, intermittent use for painful symptoms or significant sleep disturbance, and may be particularly useful for those with the intermittent form of RLS who may not want to take regular medications. A referral to secondary care is recommended if there is doubt about the diagnosis or if first-line treatment is unsuccessful in improving symptoms. If complications of treatment occur, then seeking advice and support would also be recommended, and for severe symptoms in pregnancy, specialist advice should be sought. So thank you all for listening. I hope you found this podcast helpful. Please do have a look at the show notes that accompany this episode at GPnotebook.com, and would be very grateful if you would consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email support@GPnotebook.com if you have any questions, comments, or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and download free shortcuts which are designed to help make your lives a little easier and ultimately help improve the lives of our patients in primary care.